know
Yeah,
and do little research and
yeah.
see who's going to go first in the draft.
I know draft order is like the most important thing,
Yeah,
and if that you find out the draft order the day before your draft, there's no way you're gonna like plan for it. You know, how
I
can you
know.
plan for a fantasy football draft if you don't know when the draft order is or what the draft order is? Like,
Yeah.
there's a big difference in picking sixth or like first,
Oh, dude, total
right?
game changer for sure.
Yeah.
I honestly though, I'm more interested in what the punishment is going to be for last place this year.
Yeah, I've seen some interesting punishment throughout the years. You know, some people.
Yeah.
There's one. The one we talked about was interesting, where the loser takes the SAT for the, on a Saturday for 6 hours and has to post their score and show how they did.
I think
That
that's
would be.
I think that's a great one. I mean, just the humiliation alone, the nuisance of signing up for the test, dedicating a Saturday to go take with a bunch of high school kids. Um, it's just gonna be so
Imagine,
funny.
imagine walking in like there's a bunch of 18-year-olds, 16-year-olds,
Yeah.
17-year-olds, and you're walking in a 35-year-old man that's here to take the SAT.
Yeah, it's like, why are you here? I lost my fantasy football league.
Yeah, just taking the SAT for fun.
Yeah.
That I mean, my suggestion was the loser has to have a mustache only look, but some people thought that was just a nice look to have.
Stash only. Hey, the stash is coming back, man. More and more people are keeping just a stash.
I don't know, man. I think it's still creepy though.
It's a very
I
super
don't know.
trooper vibe.
I think it is, but the fantasy football things like that, keep you distracted from all the daily hustle and bustle of practice. Dealing with those prior authorizations.
Oh gosh, no,
You
tell
did
me
a you
about it.
did a pretty big surgery this week. Did you have trouble with insurances with that one or?
You know that the insurance, gosh, the insurance game, the insurance nightmare, however you want to call it, um, it's very annoying to navigate because, like, I practice in a lot of different settings, right? I'm in academic medicine, but we have a private hospital setting. I work sometime at the VA, sometime at the county hospital, the level one trauma center. And so, each of those has its own unique insurance environment, or a lot of times at the county hospital, lack thereof. A lot of those patients are uninsured. I mean, I think something at the Houston hospitals like Ben Taub, it's something like 90% of the patients are uninsured, which means the onus is in that setting on the taxpayers and the institution. So like a big surgery, like you're talking about, we had a really large shoulder surgery. And we needed a very big graft, a cadaver, an allograft, to reconstruct part of the shoulder. And those grafts are expensive, and there's a time constraint on them and getting them. And it was a fight with the institution to buy it, pay for it, and have it ready, because it was needed for the patient's case. And same things like that happen on the insured side. That there's a special type of case or special surgery that needs a custom implant or something like that. A lot of those can become fights with the insurance companies to really justify them paying for the care that the patient needs. The patient is paying into their premiums every month and paying for their insurance for a setting like this. Yeah, you deal with it all the time.
I mean, isn't it amazing though? Just because I wish that was more prevalent, where an institution like where you practice, and a county hospital, which is taxpayer funded, was able to pay for such big and life changing, life saving surgery. Kind of like makes me feel like maybe that's where I want my taxpayer money to go, rather than unnecessary things out there that we're engaging in currently. But
Yeah, no,
saving
for
life,
sure.
saving someone's life, providing them with the chance at livelihood, the being able to be with their kids, and if my taxpayer money is going towards something like that, where someone can get a new arm or new shoulder or a new heart because and they can live a better life because of that, that's much more return on investment than anything out there, right?
Yeah, I think when you see tangible benefits of where our taxpayer money goes, I mean, it always helps rather than it's kind of nebulous. Okay, I paid my taxes. What actually happened? What materialized from that? I mean, often you don't know. Often nothing.
Yeah, often nothing, often useless projects, or the worst, even wars. I mean, money is being used to kill people that that is much more devastating and morale lowering for someone who's working hard paying taxes. But when you hear stories that you told me, someone's shoulder and scapula being saved after big cancer removal, and then them having a chance to spend time with their baby, that's a huge that's kind of like rewarding, and that's the thing with the insurances, where a surgery like that would not be possible at a private practice institution where a physician was in private practice and was planning that kind of surgery. It would be possible, but not too much incentive to do something like that on someone who's not insured.
Yeah, totally. I mean, that's the unfortunate reality, that there's almost like, in some cases, a disconnect in the ability of a patient with a really complex or challenging problem, um, and the team that's able to handle it and do it, because not all hospitals have the same resources and the same training level of providers, surgeons, nurses, the whole hospital setting. It's not just a one man show. I mean, it's a whole team to do a lot of these complex reconstructive procedures. And unfortunately, when the resources are limited, like a patient who doesn't have insurance, as an example, eh, if there's a very high profile group or someone who can take care of them and there's no one to pay, it becomes now a question of, is this a charity case or not? Or do you just not do the surgery? And then if it becomes a charity case, how many of those can you feasibly do in your practice? It's almost taboo and kind of shunned to talk about finances and money, but these things are real. That a lot of people, I mean, I'm an academic, so I don't want to speak for anyone, but a lot of people in private practice, they don't do the same volume of highly complex surgeries because a lot of them, for your unit investment of time, don't always reimburse as well. And a big reason for that is the insurance game is skewed. The compensation models, whether you are RVU based in an employed model, whether you are collections based in a private practice type model, or some mix, they're very skewed to doing a high volume of relatively straightforward primary surgery. It's almost biased away from complex cases, revision cases, and things like that. I mean, what do you think? Do you see that
Yeah,
in the way you practice?
that's exactly how it is in cardiology. In cardiology, there are procedures that can take a long time. For example, when someone has a chronic total occlusion of a coronary artery, when your arteries are completely blocked, 100% blocked, those procedures can sometimes take hours and hours. And sometimes doing that case is equivalent to maybe just doing a couple of cats, but it would take 10 times as long. Sometimes a hard cath can be done in maybe 15, 20 minutes, sometimes less with someone faster. And opening a completely occluded artery, which can be very helpful for some certain population, can take a very, very long time. So someone in private practice, I mean, they're not incentivized to do a 4 hour, 5 hour long procedure, 3 hour long procedure, when they're going to get paid for doing much more for doing maybe 15 simple procedures during that time. So it is the unfortunate reality of it, and I think being uninsured in this country can be devastating. Especially if you develop a chronic illness. We both trained at county hospital. You did your training, part of your training, and you practice at Bentab, and I did training at LBJ and University Hospital in San Antonio, where we took care of a lot of patients that are uninsured, and we provide life-saving treatments to them. There's patients that had no insurance but came in with you know complex conditions. They were able to get new valves. They were able to get new stents in their heart, bypass surgeries that gave them another 10, 15, 20 years to live with their family. And if they were uninsured, that would be a lifelong debt as well. They'll keep getting bills from the hospital of a $100,000, $90,000 procedure they just underwent. So being uninsured can be very devastating, but insurance is also so confusing, right? A lot of people don't really understand what insurance they're signing up for, and there's all
Yeah.
these key words and jargon related to insurance, like what is a premium, and what is your co-insurance, and what is a deductible, and what is your out-of-pocket expense. So those are the things I think we might be able to explain here a little bit, right?
Yeah, for sure. I mean, the landscape and the jargon is what makes anything complicated. It's kind of like when you read which no one reads. You go on a new website and you read like the end user license agreement. Everyone just scrolls and clicks it, but you just hit I agree. It's like a knee jerk reaction. I got to use this thing. I'm just going to click it. But the devil's in the details. I mean, you don't even really know what you're signing or agreeing to. And a lot of
Yeah.
times, I mean, myself included, when I got health insurance for myself and my family, I mean, I don't know every single aspect of it, every detail, every contingency. Like, God forbid, if this happens, what is the reality? What is the maximum amount they'll pay? What is my annual deductible, and what is my co-pay expected for a PCP visit, a primary care versus a specialist visit? Is it different for me and my son who's a child? You know what I mean? So all those things are very complex, and I think in some cases, not everything is with bad intentions, but in some cases things are purposely opaque because it allows people to pay more money for stuff that they don't know whether they need or not. And
Yeah.
so, like, the copay is a very common thing that almost everyone with insurance is going to do. That basically, you go into a visit, whether with your primary care doctor or a specialist, and a portion of the bill you pay, often up front. And a lot of insurance cards will say that, like, copay for visit, $25, and it'll sometimes have a distinction, primary versus a specialist, like $50 for primary, $100 for specialist. That number varies, obviously, depending on how good your insurance is. So that's a very common thing that basically everyone who goes and sees a doctor is going to have to do.
Yeah. Yeah, I truly didn't understand what insurance is and what each of these things meant until I started my own practice, and then I had to kind of explain it to the patients, and even maybe for the first 6 months, man, I don't think I truly understand insurances. 7 months, 6 months, I was like, okay, let's just bill to the insurance. Like, what does that even mean?
Yeah.
So, like, what do you mean? Like, the patient's gonna pay, or it's gonna be, I'm not gonna get any money for this procedure I just did because I didn't collect money from the insurance? Like, what or from the patient? What do you mean? So the way it works is, there, first, when you get insurance, you see an amount, a premium, right? Premium is the monthly or the yearly amount that you pay to just get that insurance. I mean, that's, for example, they say your premium for the year is $6,000. That's what you're paying monthly or yearly to get that insurance plan, right? Then the next big thing is, your deductible. Deductible is an amount set by the insurance, and some of these cheaper plans, the ones that cost less, have a very high deductible. Now, the plans are very cheap because the deductible is very high. And what is a deductible? Deductible is an amount set by insurance that the patient will have to pay everything out of pocket until they meet that amount. So, for example, you buy an insurance, and it's $7,000 a year that you have to pay for that insurance, health insurance, right? Now, on top of that, your deductible is 7,000. So, for every expense you're making, you're having to pay out of pocket. So, a physician visit, a cardiologist visit, your new patient visit is $189. So, the cardiologist will bill to the insurance a certain amount of money, and the insurance will say this is what the patient owes you, $189, and the patient will have to pay out of their pocket. And those multiple payments of 189, 450 for a procedure, 650 for an imaging study, and those add up. And once you reach that $7,000 amount, that's when you meet your deductible, right? Then comes the co-insurance, and co-insurance is the amount you pay once you met your deductible, an extra money that you owe. For example, they tell you in these high deductible plan, the patient owes 50% of the cost once the deductible is met. So not only they had a deductible, which they had to pay out of their pocket $7,000, now their imaging studies are only covered 60% or 70% or 80%. So if it's a $2,000 study, 1,600 might get paid by insurance, but the patient will still have to pay $400 out of pocket, even though they met their deductible, right? So all that out of pocket amount is co-insurance that they have to pay along as a percentage of what they owed. And the last thing is your out of pocket maximum. So once you paid all these extra costs that goes towards your treatment, then once you meet your out of pocket maximum, which could be another $10,000, that's when everything is covered. So a very cheap plan that you're maybe paying, like, $200 a month or $150 a month or even less. A cheap plan is cheap for a reason, because all the cost that you're going to pay towards is going to come out of your pocket. Insurance will not cover anything unless a huge expense happens. So what they're banking on is you're a healthy person. You won't have to go to doctors. You won't have an emergency. You won't end up having needing a surgery. So you have a high deductible. You'll pay these small piece primary care visits, maybe a specialist visit out of your own pocket. But it does save you against those devastating things where if you get into a huge car accident, have to go to a trauma center, get multiple surgeries, and your expense is $9,000. Now you only have to pay $7,000 deductible or out of pocket, and then and the rest is covered. So that's that. But there are some plans that are pretty good. They're expensive plans, but they're only plans where all you have to do is pay your copay. So you show up to a doctor's office, you pay $25 copay, and you get all the studies and everything else is covered. But then the premium was very high, and the
Yeah.
cost.
There's and that's just like a brief overview of it, but it's stuff like this that makes insurance so annoying. And especially, when you put it in context of real life. Like, I'll give you an example that happened to me earlier this week. I have a patient, a 72, 73-year-old lady, and she fell about a week and a half ago, just walking in her house. She's active, she's older, but she's a pretty active lady, not majorly sick or anything. Does all of her own stuff, goes to the grocery store, her and her husband walk the neighborhood, they take vacations now and then. A normal, pretty healthy 70-some-year-old lady who fell. And she had a really bad fracture, dislocation of her shoulder. She broke the humerus, the proximal humerus, and it dislocated. It's a pretty bad injury. Obviously, she's in remarkable pain. She went to the ER. They tried to align it. They took the x-rays, gave her a sling, and had her follow up with me. And so, I see her in clinic, and I talked to her and her husband that this is a really bad injury based on your age, the amount of fragments of the fracture, all this stuff. The best treatment for you is actually a shoulder replacement. Okay, which is not an uncommon treatment, especially for older people, to do a shoulder replacement for a bad fracture in the shoulder. It's stable, it helps with the pain, they get their motion back. It's a pretty reliable treatment. And so obviously we go through insurance and all this stuff like we do anytime we book a patient for insurance for surgery, and the insurance company denies the claim. The insurance company says that because all they're looking at is these checklist items. They have the procedure code. In this case, the procedure code is just a shoulder replacement. There is not a distinction between I'm doing a shoulder replacement for just arthritis versus a fracture, which is a more urgent matter. All they see is shoulder replacement, and they see this patient has not done 12 weeks of formal physical therapy. This patient has not had a steroid injection. And so they deny it. They say this is unindicated because the patient has not yet failed physical therapy and steroid injection. And I get the claim back, and I was like, what are you talking about? This patient's humeral head is literally dislocated. The humerus is in 4 different fragments. This lady is miserable. And now we have to do this back and forth nonsense with the insurance company because they just have a default knee-jerk checklist. There's not really a human reviewing it. And if there's a human reviewing it, they're just looking at this itemized list that doesn't give them any information. So I had to do a peer-to-peer. We wrote an appeal letter, but it's just, again, instant rejection. It was almost as if they hadn't even read the appeal letter, which very clearly said this is not a routine case. This isn't just someone with arthritis that I'm money hungry trying to sign up for a shoulder replacement. This person has a problem that can only be fixed by this. It's a trauma. So I had to get on the phone, and I did a peer-to-peer with this person from the insurance company who was an employee of the insurance company. And I just asked him, I was like, are you still practicing? And it turns out they're a retired family medicine doctor who hasn't practiced in over 15 years. And I wasn't even being rude. I was just being genuine with the person on the phone that, to be frank with you, you're not my peer in this setting. This is called a peer-to-peer, but you're not practicing and you haven't for 15 years. You're not a surgeon. You've never done a shoulder replacement. You've never treated a proximal humerus fracture dislocation. How are you the designated peer from the insurance company who literally has the decision to dictate whether this patient's care is going to be approved or not into a payment plan she has been putting in money month after month for year after year just for a situation like this? And the person on the phone was just like, well, we have these protocols. And I was like, dude, forget the protocols. I'm telling you, this patient has a horrible fracture. Did you even look at the x-rays? Do you have the context for that? And that's the issue with this insurance game. And Humayun, I'm sure you have examples, so many examples of your own. I have numerous like this. Eventually, thankfully, the patient's care got approved, and I was able to get her on track for the surgery. But this stuff happens so often, and the amount of time and extra wasted energy to do this, and this kind of lobbying back and forth, volleying back and forth of these issues in this discussion, just to get our patients the right care they need, because the payer in this setting, the insurance company, just doesn't want to do it.
Yeah, I mean the peer insurance company is a corporation, and their goal is to maximize their profit, and their goal, their their loyalties lies towards their shareholders, right? In the end, they need to see on S&P and Nasdaq what their next earnings are, and and report to their board and the shareholders of why the earnings were less. So their goal is to maximize their profits and not pay for things, and maximize the profit by collecting as much money as possible from patients and paying for least amount of things possible. So is that's how that is the nature of the system we practice in. It is very frustrating, just basic things like getting a stress test. I mean, I have to do tons of these peer to peers with for stress testing, and it's mostly a non cardiologist on the other hand, and you can tell from right away from the first like sentence they say if your peer-to-peer will be approved or disapproved. And a lot of times these physicians on the other end, they agree. They said, yeah, I mean, it makes sense, but this is what our protocol says, and the protocol is in front of them. They said, oh, you have to do a basic exercise treadmill test first before you do a nuclear exercise treadmill test. But a nuclear stress test will give you much more information about the heart's condition and the lack of blood flow than a just basic exercise treadmill test with an EKG only. And they always want you to do that first, and it's like, okay, no, but that's not what I'm looking for. I'm looking for I'm looking for ischemia or lack of blood flow to the heart. I mean, that's what more information I need. But this never they're like, yeah, we get it, we know, but this is what our guidelines say, so this is what you have to follow. And it's a lot of times frustrating. And I know a lot of doctors out there that have even stopped ordering certain tests because they're like, it's not worth the hassle of waiting for the phone call, getting on the phone. It's not like you can just pick up the call and be like, hey, I want this approved. You have to call them, wait on the line. Someone from the staff has to stay on the hold for a long time, give them all the information, fax
Yeah.
the record, they have to review
It's
it.
the worst. They give you like a window as if it's like a repair for like if someone's coming to repair your toilet at your house. And it's like,
Yeah.
okay, we'll be there from 8 to 12. So just be
No, it's not
available.
even that. It's not even that. Yesterday, I had a peer-to-peer schedule at 12:15. My clinic ran longer, and I had two more patients to see, so I was going over time, and some patients needed a little bit more information about their procedure that I'm about to do on them. So it's just longer, and at 12:15, my phone rang, and I missed it because I was talking to a patient in the middle of the chat, and that was my only opportunity to do the peer-to-peer, and now my staff had to get on the phone again, stay on hold, tell them again, set up a new time, and luckily at 4:45 p.m. I was able to get on the phone and do the peer-to-peer for a stress test the next day. So the patient was waiting, I was waiting, the staff was waiting, and at the end of the day we finally got it done. But it's just a hassle, and it takes away from your clinic and patient care time. It takes away from writing notes. It takes away from talking to the patients and running your practice, and it's just a pain. And that's why Medicare sometimes it's easy, right? Medicare for me is a Medicare patient comes in, I order a test, it will get done because Medicare does not right now currently. I mean, I think in the future there are plans to implement prior authorization in Medicare, but right now Medicare procedures and tests do not require prior authorization. So if I order a test on a Medicare patient, it will get done. Yeah, I'll get paid a lot less, but it'll be easy. It's easier to take care of those patients and requires less staff, less resources to take care of Medicare patients. But just because every year Medicare payments keep going down, so a lot of physicians stop taking Medicare because sometimes it's not worth taking those patients. I still enjoy seeing Medicare patients, and I think for me they're easy. But that's the key. Medicare is government run, so they are not focused on profits versus private insurances or corporations, and their focus is maximizing profits, right?
Yeah, and that's something that it's very frustrating for a lot of my friends who are in private practice. I mean, there's a lot of them that just straight up do not take Medicare. Like Medicare patients are not seen in their clinics and their practices. They don't operate on Medicare patients, and it's not that they dislike people above the age of 65. I mean, it's purely because of the finances that running a practice is running a business. And if you can't exceed your expenses with your revenue, you're not going to survive and you're not going to then take care of anybody. And so it's not just, the incorrect cliche that, oh, these doctors are just looking to make more money. They don't want to take Medicare because it doesn't pay as well. Their practice and their overhead and their business model may simply not allow that. It may not be feasible to keep seeing those patients. It doesn't mean that they're cherry picking just to be greedy. A lot of that is basically the finance, like Humayun, you're talking about, right? That the Medicare payments, the reimbursement has historically been cut again and again and again. And obviously private insurance, these commercial insurance plans, they pay higher, right? They pay some multiples of Medicare. Um, and so that incentivizes people a lot. That's just the reality.
Yeah. Yeah, like if you have 40 patient slots in a day and that's all you can see in one day, and out of those 40 patients, if your 10 of those patients are Medicare, and but on the wait list there's 20 other private insurance patients waiting to be get on your schedule, then as a business it's much more prudent to schedule only private insurance patients because the returns will be higher. You'll be able to pay your staff salary, take care of your expenses, and some practices depend on that because their overheads are very high. They're paying, the cost of running a practice keeps going up. The regulatory agencies have put in so many requirements where you need to hire more staff to make sure you're meeting all the regulatory requirements, and that makes a private practice very tough to do, because just of something. Maybe 10 years ago, a medical assistant would get maybe paid 11 hours, $12 an hour, $13 an hour, and now it's hard to find a medical assistant for less than $20 an hour. So it can be challenging, and as the overhead costs have gone up of running a practice, the payments from Medicare have gone down. So it's a inverse relationship, and you don't ever see that. Something that I remember 3 years ago when I started my practice, an echo through a Medicare patient, an echo would pay maybe $210 or $212, and this year it's $195. So in what industry do cost of doing a service that the quality hasn't changed, the need hasn't changed, but the price that you get reimbursed goes down, and the cost of doing that service goes up, and because of that, I mean, a lot of people are moving away from these Medicare plans, and these Medicare Advantages are taking advantage of this as well. Medicare Advantage is pretty much private insurances getting money from the government to provide health care for patients. So what they do is, they say that, for example, Blue Cross Blue Shield's Medicare Advantage plan. Now they say that we will, take that Medicare assigned money and use that to provide care for a patient, but then they bring in all the private healthcare jargon in that, where you do need prior authorization. There is a certain copay. There's a higher deductible sometimes. Sometimes procedures do not get covered with these Medicare Advantage plans. So it is government subsidizing these big corporations, but they're also running that insurance just like a Medicare, just like a private insurance plan. So that's another complicated thing, the Medicare Advantage, and they keep growing and growing. And I think there's a push from the current administration about making Medicare Advantage more prevalent.
Yeah, I mean, in most things, in a lot of things, privatization of stuff can lead to innovation. It can make things more efficient, rather than nationalizing industries. I mean, we've seen that a lot of that is capitalism, but it begs the question, right? And this is maybe like a bit of a philosophical and ethical question in addition to just logical, but is privatization like this with the health insurance in medicine really like the best way, the right way? And does it actually increase efficiency of care? I mean, I find that in a lot of ways it decreases efficiency because there's so many extra checkpoints to hit for even what would seemingly be simple stuff. Someone comes in with an injury, they have a broken bone, they need to get it fixed. And like in the example I gave for the patient's shoulder placement, there's these roadblocks because of the prior authorization knee-jerk reaction of denial, or just looking at a few hot button items and keywords and buzzwords. It also adds work in the clinic, and a lot of doctors, a lot of providers will purposely put information in the note for insurance companies. It's almost as if the note is now like a ledger to justify what you're doing rather than actually just detailing the true purpose, the history, and the physical of the patient. You're putting all this stuff like for example, for interpretation of imaging, like an X-ray, for example, I can't just say patient had wrist X-rays that demonstrate blank, a fracture of the distal radius or arthritis in the DRUJ joint. I have to mention that 3 view radiographs of the wrist were taken on blank date, and they did because there is just specific criteria that have been put in that will make the insurance company either accept this now as an added portion. You've reviewed the imaging or you didn't. And so it's almost like adding extra stuff every so often, extra stuff every so often, because some people won't catch on. Some people won't find out until later. It's not like we get a list every week that here's the new stuff that blank Blue Cross Blue Shield said, or United said, or Cigna said that you got to do. You just got to find out as you go, and you find out when something's denied after the fact retroactively. It's a huge nuisance, and it creates more paperwork, more time, more effort. It delays you from seeing additional patients. It adds a big inefficiency, I think, in your clinical practice.
Yeah, it keeps getting harder to see patients, and then there's the other complication of different types of plans, right? So there's multiple types of insurance plans. So there are HMO plans, there's PPO plans, there's EPO plans. So patients should also be kind of educated about what kind of plan they're signing up for. HMOs are plans where there's a limited set of providers, physicians, primary care specialists that are part of a group, a large connected group where they can only refer patients within that group. So for a lot of the HMO plans, you need a referral, and if you don't have a referral and you're not in the network, you cannot see that patient. And if the patients want to come to you, they cannot because you're not part of that HMO network, or the primary care does not want to refer it to you. So that is the HMO plan. They tend to be a little cheaper, but because they're limited.
I'll just tell you as a quick aside, like we see that nuisance so often because I mean, everything is so hyper specialized. Like for me in orthopedic surgery, we're so subspecialized in our thing. Like I do upper extremity stuff from finger to the scapula. And every now and then in the clinic, like our goal is to get patients in if someone has something wrong. So I'll see someone like there's a patient with low back pain or sciatica or like a toe injury or something in the clinic. And rather than wasting that patient's time and my time, because it's not what I do, and if they have like a surgical problem, I'm not going to operate on someone's toe or their lower back. I have partners that do that, and they're experts in that. They went to fellowship for that. Rather than just switching them to my partner's clinic, who a lot of them have clinic on the same day, the patient's already there, it would be immediately easy for the patient, no extra time, no need to reschedule their life, their work, their child care to come in and see someone on a different day. But then we find out, oh shoot, this guy's got an HMO plan. He's got a direct referral to me. We can't switch them. We have to now contact the patient's primary care doc. They've got to send a new referral for the different provider, and then they can see him. And often that doesn't happen that same day. And so because of the restrictions like Humayun you're talking about in a lot of these HMO plans that mandate a direct referral to that provider rather than a more generic referral to the orthopedic group or for this specialty care, a lot of times the care gets delayed. They have to get shifted to another day, or they end up being forced to see a provider that may not be able to meet their needs. And now they've paid that copay, plus they have to still go see somebody else. That happens a lot. It's very frustrating.
Yeah, and patients like, wait, I didn't even get care, and why do I have to pay the copay?
Yeah, and
Yeah,
the
because
patient
you're
get
on
pissed.
schedule.
They get pissed at us, even though it's the patient's insurance company who's making these rules for them, and the patient doesn't even know it. We're often the first person to educate them about their own insurance plan, even though we're not insurance individuals.
Yeah, it's exactly their insurance, and they cannot even get in touch with the insurance agent who can explain to them what their plan means, right? A PPO plan, for example, unlike HMO, you can choose any specialist you want. You can go directly and bypass a primary care physician and go to a cardiologist, an endocrinologist, an orthopedic surgeon, and then the issue comes in where patients just completely bypass a primary care doctor and they only see specialists, and then things like a basic flu vaccination or a colonoscopy referral gets missed because for them it was easy to just see specialists for the certain needs they had. But the PPO plans are expensive and you have to pay a ton, right? There's a middle ground of EPO plan, which is a limited network, cheaper plan, and within the area where you can go to any specialist, but those can be very limited as well. So honestly, there's no one good plan. Each plan has their own advantages and disadvantages. Medicare has its own advantages and disadvantages. Medicare Advantage plans have their own advantages and disadvantages. But the hard part is within this, we as physicians are the ones who are having to deal with it and be on the front line and feel the anger from the patients when they have a certain cost, right? I mean, a lot of times, for example, we schedule imaging studies, procedures, nuclear stress test, echo, all these kind of tests in my office, and our staff has to be on the phone. You literally, there's to find out how much a patient will have to pay. We have to stay on the phone, wait for an agent. The agent may or may not tell us the right information. Sometimes you talk to one agent, they tell you, oh yeah, the allowable for this procedure is $150, but then you talk to another person, there's no collectible, and there's, a copay of $20. So you get sometimes deferring information from the insurance agents about the plan the patient has. And then, that's when you have to tell the patient, okay, we're collecting $189 for this procedure, but you have to warn them that this is just an estimate. And once we send the bill to the insurance company, they will send you an EOB with explanation of benefits that will tell you that this is how much was billed, this is how much the allowable was, and allowable is something that the insurance says that that's all that this physician can bill. So, a lot of times what happens is a physician practices, for example, it's an echocardiogram in my practice, right? And we bill the insurance $650, and that's what they tell us, that's what you could bill. That's usually a negotiated amount, right? And then what the insurance says the allowable was $300. So you bill 600 and you get paid $300, and the other $300 is a contracted write-off that you have to write off. And but sometimes patients get a bill and they say, oh, you charged me $600 for this. What do you mean? That's very expensive, and this is not what I got. But that's not what you got charged. That's what the insurance was billed. The insurance paid $300. Now your portion is $20, and that's what you have to pay. So just explaining that, we get so many angry calls whenever statements go out from our practice, from patients complaining, but hey, this is the insurance is telling us what to collect and what you have to pay. This is not something we decide as physicians. We do not get to decide what we collect for a certain service we're providing, and we're probably the only industry where someone tells us how much money we can collect for a service we provide. Unless
Yeah,
we go,
it's crazy, I mean, and we were talking about this a little before we started the episode about cash pay, and essentially like getting out of this insurance stranglehold on the ability of a physician and a patient to enter a relationship and the doctor to provide the right care for the patient. More and more physicians are entering direct care models where it's basically transparent. The patient and the doctor know the price of services. They discuss it, and you just decide, okay, I'm going in for my primary care visit. I want to get a battery of labs, and this is the cost of this, and this. Okay, oh man, money's a little tight right now. Maybe I won't get that one. But it's just like an honest conversation rather than it, for one, being taboo to talk about money with your doctor and your patient, and two, the fact that someone else is paying, and now it's kind of arbitrary. I mean, like you're talking about, Humayun, like having to be on the phone and calling the insurance to figure out if a patient can get the service they need. I mean, patients come to my clinic with like a wrist sprain. We have wrist braces in clinic. I mean, how easy is that to just give it to them? But now, like in a lot of patients' insurance plans, we have to like call the patient's insurance company and make sure that it'll be covered. And I mean, I like, maybe it sounds bad. I'll just tell patients like, look, if it's not covered, I mean, go to Amazon.com or walk into a Walgreens and get one for like $12. I mean, it's just annoying that I can't give it to you here in clinic for that nominal fee because I'm your doctor and I have it. It's just so dumb. But I think that direct care model is a real interesting thing, and I'm happy to see it growing. Even though that's not my practice model, I think it's awesome that some patients are able to do that and some doctors are able to practice like that, because I think it's very refreshing for the patient to one have the transparency and know I'm paying this much and this is what I'm getting, and for it to be immediate rather than now you wait and delay. And it's not necessarily a surprise bill; it's just a delayed bill. Everything in healthcare is a delayed bill. Like you don't even know what it's going to be. It's like every time you go to a restaurant and every single menu has zero prices, and it's like good luck and guess what it's going to be at the end. Some super fancy restaurants do that, but it's not the norm. That is the norm in our industry. That's the norm in healthcare. It's like you have a menu and you order a bunch of food and you just good luck, whatever the price is going to be at the end.
Yeah, it's both from the physician side and the patient side, right? The patient comes in and they don't know what their true cost will be for a procedure, and they're maybe getting an estimated cost that the physician's office had to stay on hours on the phone with certain insurance company. Hey, tell us what will his echo cost? How much can we charge him? And then you get that cost and you put that on the patient's chart that this is what we need to collect, and the patient comes in, they're paying the $180 that was told to their physician's office by their insurance company, and then 2 months later they get a bill for another $50. Hey, this is what truly your cost was. And even we don't know if we will get paid for a certain procedure we're doing or certain imaging study we're doing. We don't know. You can't plan for that. I mean, we have a certain estimates and idea, and it's all about the rate you negotiated, right? I mean, yeah, that's why small practices and smaller private practices that are on their own are having a harder time, because in a lot of cities, unlike Houston, a lot of cities, it's very hard for a private practice to get good insurance contracts where they can go in and negotiate with the insurance company. Hey, no, for this service, this is how much I want to get paid by you versus insurance telling them, no, for this, a hospital will make $5,000, but you will only make $500. And that's the unfair advantage a lot of these bigger corporate hospitals get, because they can bill and charge and negotiate with insurance companies at a much higher rate compared to a private practice physician on a smaller level who cannot negotiate those rates. It is very prevalent in a lot of East Coast and West Coast cities where physicians are completely priced out of private practice, where in Texas and Houston it's still possible because we have a lot of these physician networks and organizations where we can pool in our resources together and negotiate together as a big group with insurance
Yeah, I
companies.
mean, it's collective bargaining, just like the NBA did when the players got together. It's the same idea, and I mean, it's worked here in states like ours in Texas. I think it's like a form of unionizing in a way, and more
Kind
states that are doing it.
Yeah, kind of, but the it's moving away from that. I don't know what the future of medicine will be like, because a lot of that will go away. It will unfortunately get harder and harder for private physicians who are incentivized for providing good service because they want to retain patients and provide good care to patients. That will slowly go away, and the corporate takeover of medicine will continue. There will be some people that will, try to be, and not saying that big corporations cannot provide uh, good care, but the incentives a lot of times different, because the people who are making decisions are focused on bottom lines rather than the patient care. And we're physicians, it's in our DNA to focus on patient care. I mean, there are bad apples out there. There's physicians that are completely profit focused and only care about money, but most physicians, it's in their DNA to first focus on patient care, and the money comes with it, but patient care is more important to physicians than someone who got an MBA and all they learned is balance sheets and bottom lines.
Yeah, for sure. I mean, even at the big corporate level, right? Like, I mean, when we have our institutional meetings, and not just us, I mean, every big institution, we may not worry about, like, for instance, when a patient comes and sees me in clinic, being the fact that I'm an employee in an academic model, a lot of times I don't even look. I have no idea what insurance the patient has. I mean, whether they're some Medicaid plan, Medicare, an HMO from United, PPO from say, I have no idea, because it makes zero difference to me in a meaningful way in terms of my practice, because I don't get paid any different regardless of what insurance a patient has. I'm RVU based, so I'm based on the unit of work that is assigned to each surgical code. Regardless of what insurance it is, that doesn't change. Now, my employer, my institution, the academic center, or if someone's hospital employed, for them it matters because the payer mix is a huge factor. The more commercial plans, the more, I guess you would say, better plans, right? they have contracts with these companies, and so the institution, when they bill for the services and their facility fees, they have negotiated much higher rates with some of these institutions. So to them, it's very advantageous to have a payer mix that is very high percentage commercial insurance rather than what's like government insurance, Medicare or Medicaid, because then the institution makes a lot more money, even though the individual employee, doctor like myself, in this model sees no meaningful difference. It has no bearing on my practice. It definitely has a bearing on the institution, and that's really what dictates a lot of the advancement and growth of these institutions, where they have these satellite clinics all over the place. They often will have a lot of little clinics and access points in affluent suburbs, because those affluent suburbs have a very high percentage of commercially insured patients and professionals that live there. Therefore, those people have insurance. They're going to go and see doctors with their insurance plans. And now, for that same care, that institution is going to make relatively more money for the same care provided compared to someone who might have had a Medicare plan or a Medicaid plan. That's very relevant for the institution for sure.
Yeah. No, for me, I always, whenever I'm seeing patients and about to order certain tests for them, I always open up their insurance benefits and see how much will they have to end up paying. And every time I see, oh, $20 covers all their studies, I'm like, okay, well, great. I mean, you won't have to pay as much for this. I always keep that in mind because, I'm seeing a patient, and if I just blindly order a stress test, an echo, and a Holter monitor, and a cardiac CTA, and I just blindly order it, the patient will end up having a huge cost, and they won't know what to do, what not to do. Sometimes not everyone has that affordability, so I always tend to have that discussion with patients, especially those with a very high deductible. Hey, this is the test I think we should get because will give us the best answer, but these tests will end up probably costing you around this much money. The second best option, which is a little cheaper but will maybe give us some good answers, is doing these two things instead, where it's not as ideal, but the cost will be lower. Now I'll let you decide what you think is the best based on your finances, because in the end you will have to pay. Now a lot of times, I do that because I personally, when I'm seeing patients and I hear about how much they will owe for this procedure, I hear they canceled that because they couldn't afford it. I just personally feel bad, and I'm like, I wish it didn't cost that much. And a lot of time, if it's in my control, I tell my office staff, hey, why don't we give them a little discount? Why don't we do maybe a 50% discount on their co-insurance? Yeah, if they owe $800 for the cycle, why don't we cut it down to $400 just so they could get that study? Because I can make that decision, being in ownership of my practice, but then it can get a little dicey as well. I can't do that for everyone because that can get me in trouble with the insurances. It can get me in trouble with the government because it's anti-competitive. If I do that on everyone, I'm undercutting other competitive cardiologists that will not be offering the same kind of cost cuttings or discounts, right? So you can't do that for everyone. You have to pick and choose if a patient truly needs it and they really can't afford it. Knowing their situation, knowing their financial situation will help me decide, okay, this is, maybe I can cut the cost for you, maybe give you a payment plan, maybe write off that echo and give that to you for free, just so right now let's get it done, and maybe you can think about paying for that in the future. But I can't do that completely, just cut down the cost for everyone. So
Which is so ridiculous if you think about it in like the context of all other small business in the United States. What other small business is there in America where the government and insurance companies can actually tell you that you're not allowed to charge your customer less?
yeah
Like
yeah
you have to charge them more, otherwise you're in potential violation of antitrust and kickback statutes. It's ridiculous to even think about it that way, but that's really
I mean,
what's happening.
the insurance can take away your contract, and they can kick you out of their insurance plan because you've been doing that, and that's not fair to other doctors who have that contract as well, and they signed that contract of collecting that much money from a patient. And I want patients to know it's not that we're deciding the high cost that they have to pay. As
Yeah, it's
physicians,
pre-negotiated. The insurance contracts that every physician enters, every group, every practice, every hospital, every academic group, everyone enters into a set contract with a full list of stuff. It's predetermined. It's not arbitrary at all.
yeah, it's not, and getting that information, because you may have a Blue Cross Blue Shield plan, you might have a United Healthcare plan, but there's 10 different variations, 50 different variations of a United Healthcare plan or a Blue Cross Blue Shield plan where a different employer agreed on different different numbers and different deductibles. So there's no one plan, and I might be in network with Blue Cross Blue Shield with 10 plans, but there could be one plan in Blue Cross Blue Shield that I'm not in network with. And then the patient said, "Oh yeah, you told me you're in network with Blue Cross Blue Shield, but now your office is saying you're out of network. You wasted my time by telling me yes, you were in network. What does that mean?" And it's hard to explain to patients, "Hey, no, this is not how it works. I mean, this is not as simple. It's not just, yeah, take my money and treat me. I wish it worked that way." And
Yeah.
honestly,
You know,
unfortunately,
if it worked that way, then we would be like dentists. I really think in this sense, I'm not even kidding, and I am, applauding the dentists in this, that they have really maintained control of their relationship with their patients far better than we as doctors have. Like when I go to the dentist, I mean, I have dental coverage or a small element of dental coverage as part of my overall healthcare plan. But if I want anything extra, it's such an honest. I just ask my dentist, like, hey, how much is that going to cost? They always ask you, like, do you want this extra fancy super fluoride, whatever, on your teeth? And I was like, I don't know. It kind of what you just told me, Humayo, in your practice, where, here's the one study that's probably the ideal, but it costs blank. Here's the next tier that costs blank. That's not at all as easy across the board in medicine. But in dentistry, I mean, they'll just tell you, yeah, okay, this one's like $130, this one's $80, this one's this. We could do that. And dentists routinely will give discounts for people that don't have dental insurance. It's a very common thing, and they're not restricted in any way. They're very open to provide the care they want at the price they want, and they can meet patients where they can get the care. I think that's a beautiful model, and I really wish more of healthcare for doctors was like that.
well, in physician, plastic surgery works that way, right? I mean,
Yeah, in
if someone
cosmetics and cash pay it does. Yeah.
in aesthetics and cosmetics, if someone wants a breast implant or a BBL, like they will pay cash pay. But when they come to for cardiac clearance and I need an EKG and echocardiogram and their insurance will not cover that, paying that much money it's a little hurtful because something that you cannot see, your cholesterol, your hypertension, that is not outwardly as appealing or aesthetic. Maybe it's a little hard to pay that kind of money for. But if you're getting something externally aesthetically beautiful, like beautiful teeth or a beautiful nose or a nice butt, like that's worth paying for sometimes.
Oh,
And
for
and
sure. I mean, it's a sense of identity, right? Like, it's vanity, which all of us have to some extent, and it's your identity. It's your outward appearance, is what people see.
yeah, but yeah, I mean, we can keep going on this insurance because this is a daily frustration, and it's a major cause of burnout for a lot of patients. I mean, we previously talked about physician burnout, and dealing with insurances, dealing with having the staff deal with insurance, dealing with the patients who are angry about their cost is a big part of burnout. And the in an ideal world, a patient would come in, they won't have to pay a single penny to me. I would treat them the way I want them, and then everyone goes home happy. But that's we don't live in utopia.
Yeah. Amen to that. Amen to that.
All right,
Well,
man.
all right, guys. Thanks for tuning in.
All
We'll
right.
catch y'all
See you guys.
later.
Three dots, one mic.